Let me first begin by introducing myself. I'm Mark McClellan. I'm the director of the Duke Margolis Center for Health Policy. I know many of you here, but not all. Welcome to this first meeting of the North Carolina Council on Healthcare Coverage. I just want to briefly thank all of you for taking the time to be here. We have a number of distinguished members of the North Carolina legislature, healthcare leaders, including some who are both, four members of the North Carolina General Assembly who are in the health professions. Dr. Baker, Representative Adcock, Representative Cunningham, Representative White. For all of you who are in healthcare right now, we know this is a very busy and challenging time, and really appreciate your taking the time for this important issue of working on coverage. I'm going to talk a little bit more about the commission and about the council and about the Duke Margolis Center in a few minutes, but right now I'm very pleased to introduce our leaders. We're going to hear opening remarks first from the Honorable Roy Cooper and then from Secretary Cohen. Governor, please go ahead.
Thank you, Mark. I appreciate everybody coming today, and I know that this pandemic has turned everybody's life upside down. It's affected the way we work, the way we interact with our families and our friends. And I'm glad that all of you are here to talk about the important issue of healthcare coverage. Tragically, we have lost more than 5,300 people to this pandemic in North Carolina. And it is also, I think, shining a big light on a lot of the challenges that we already know are here in our state, particularly our fractured healthcare system and people who have trouble getting access to healthcare. We see it in our rural communities that are greatly affected by what's happening in our rural hospitals. We see it among the frontline healthcare workers who are having to take risks to work so hard during this pandemic. And we see it in our historically marginalized communities that have been inequitably affected by this pandemic. But I think this pandemic also has shown how our state can come together. I'm proud that North Carolina has responded in the way that we have. Our healthcare providers have gone above and beyond. And as I often talking about, thank law enforcement officers and first responders and firefighters when you see them. Thank our healthcare workers when you see them, because they are out there working hard every day and taking risks. I think our business leaders have persevered through all of this, and I'm grateful for their long leadership. And I want to thank the legislative leaders that have agreed to come and be a part of this council today. We've all worked together to get the help that we have desperately needed in testing and in contact tracing and vaccine distribution. And in addition, you've come together to help small families and businesses and people who are risking eviction from their homes. So we appreciate that. But there's a long way to go in fighting this pandemic, but I believe that we can come out on the other side of this thing stronger. But to get there, we've got to tackle the shortcomings in the system. And the fact remains that we've got at least 1.2 million North Carolinians who don't have access to healthcare coverage. And that's why I'm glad all of you have agreed to come and be a part of this process. Dr. Mark McClellan of the Duke Margolis Center is going to coordinate this council. Hemi Tararson, who is the former health policy director of the National Governors Association, a bipartisan group of governors that looks at these issues, she's going to help lead the effort as well. And our goal here is not to develop any specific policy, but to outline key principles and beliefs that can serve as a framework for later detailed discussions that we can have about how we can provide more healthcare coverage to people. And I think this council is a way where we can have a wide range of voices being heard. And I'm grateful that so many business leaders, community stakeholders, legislators have joined to become a part of this council. I think lack of healthcare coverage has far-reaching implications beyond the individuals that are struggling. It impacts our workforce, it impacts our economy and economic development, and it impacts our hospitals, that some of them, particularly in rural areas, are struggling to survive. So we hope that this can provide a good framework and starting point among people here who all care about North Carolina and who all want North Carolinians to get the proper health care. This is not going to be easy, but I'm grateful for your willingness to gather today, to listen, and then to participate in discussions as we go forward. So thank you, Mark, and thank you, Dr. Cohen, for your strong leadership of this state. I'm particularly glad to have legislative leaderships from both sides of the aisle here today to talk about this issue. Thanks, Mark.
Governor, thanks. Thank you for taking the time and effort with so much else going on to address this important issue as well. Secretary Cohen, I'd like to turn to you now.
Great. Good morning, and thank you, Governor. Thanks, Dr. McClellan, for bringing us together. I know I see so many friends and colleagues here on this council, and I'm so appreciative that you are lending your time at such a busy moment in everyone's life. This has been a hard year in particular for everyone. So I'm very grateful during this time that you're just taking a little bit of time to do this for the state of North Carolina. It's really important. I know we've been, that I have had one-on-one conversations with nearly all of you about how we can build a stronger and healthier North Carolina. And there are a lot of really good ways in which we've already worked together on that, whether it was responding to the opioid crisis or thinking about how we continue to strengthen our Medicaid program as we've transformed it, and investing in health broadly, improving mental health access to mental health services. So I know the folks who are on this council see different pieces of health in different ways and have such an important role to play, but also are so committed to this state and the health of this state and the future success of this state. And so I'm excited for this opportunity for us to explore what other states are doing to strengthen their healthcare systems, what we can learn from them, and what other ideas we can bring to the table. I think it's been really important for us to hear lots of voices. I am super appreciative of the Duke Margolis Center with Mark McClellan, and particularly Jaime, who has worked with states on challenging topics and brought consensus out from those processes. She's a master. So thank you, Jaime, for leading us here, because like I said, I think there's so much more agreement here in North Carolina than meets the eye. And so I'm excited to find those ways of pulling together and thinking about principles. I also know that we're going to be talking about coverage, but we know coverage is only one piece of access to our healthcare system, and it also rests in a lot of other issues and concerns that I've heard you articulate about our healthcare system. Cost being one of them, making sure you have access to providers. Just because you have an insurance card, are there going to be doctors and nurses to care for you when you need it? We're working through all of those kinds of issues, and with the COVID crisis, I think that has shown an even brighter light on these issues. So I hope that we can explore all of how these things layer together as we go forward. So we're going to hear from a bunch of experts today. I want to thank particularly our colleague from Ohio, Greg Moody, who's going to speak later, some of our academic colleagues, Mark Holmes and others, and then you'll hear from Dave Richard, who runs the Medicaid program here today. So I think, but I hope this needs to be collaborative, right? And I hope to hear from, you'll hear little from me and then hopefully much from all of you over the course of today, as well as helping us shape future agendas. I know Jaime is going to get to that at the end, but as you're sitting here thinking, please start to think about who are other experts, what are topics we as a group need to explore more deeply that we can bring some experts in our coming meetings. So with that as our charge for the day, I will turn it back to you, Mark. Thank you.
All right, thanks, Mandy. And just a brief introduction for me and the Duke Margolis Center, for those of you who aren't familiar with us yet. The center has been around for a few years now at Duke University. It's a university-wide program that has a mission of leading research, education, and actual practical implementation support for policies to improve health and the value of healthcare for all. And we work on these policy issues here in the state and also nationally. A lot of our team is based in Washington, D.C., where recently we've been involved with many of the reforms that the Centers for Medicare and Medicaid Services has been implementing in new ways of paying for care, things like the state's Healthy Opportunities pilot to help get focus upstream on preventing health problems and helping people lead their best, healthiest life, not just thinking about downstream costs, and also new ways of delivering care. So in the context of the pandemic, we've been doing a lot of work related to innovative healthcare models, relying on telehealth, integrating public health and healthcare services around improving testing. We are working on some projects related to vaccinations and other innovations in medical technology as well. So if you want to learn more about us, please go to our website. And I know we're working with many of you already on the COVID response issues here in the national context. And we do have some more work ahead on that front too, but it's really brought to the forefront the importance of access to innovative care and coverage. And the reason that we set up the center here was that North Carolina is really the place to be. It's a state with very innovative healthcare, not just at Duke, but at many of the other organizations that are represented in this group. And it's a place where people don't mind sitting down and working together on practical solutions. In my previous work in government, when I headed the Center for Medicare and Medicaid Services, previously had worked at FDA as well, those are the solutions that last the most. And, we worked out when I was in a Republican administration, we worked on innovative ways of doing coverage in Medicare, the Medicare Advantage program, Medicare Part D, ended up being a kind of special public-private partnership that's now an established part of Medicare. We've worked on innovative coverage reforms as well in the Medicaid program, keeping in mind the importance of protecting state budgets and also encouraging people to take steps to be healthy and improve their well-being, something that state programs can support. So we're hoping to bring a lot of that approach that's what we want to make a hallmark of the center to supporting these efforts as well. Our goal is to facilitate this group around the topics that the governor laid out. So this is not about getting to specific detailed budget numbers. It is about finding a way for us to move forward together on key principles for reform and key goals that can improve access to care and do it in a way that continues to encourage innovation, private sector engagement, and fiscal sustainability, just like we've done in many of our projects before. This is not going to be easy, but again, I can't think of a better group to work with on this, and that's why I'm in North Carolina. This is a place that can lead the way in terms of healthcare innovation and working together on practical solutions to hard problems. So with that, I'd like to turn to introductions to the rest of the group. You all are going to be playing the critical role in determining what we can do here, and want to start with our leaders from the North Carolina legislature. And if you all don't mind, I'm going to call on you, ask you to just introduce yourselves very briefly, and then we'll go to the other members of the council. I think Representative Adcock, you're with us.
Yes, good morning. I'm a Representative Adcock, preparing to start my 4th term in the House. I'm a family nurse practitioner of 33 years, and until just recently was the Chief Health Officer for SAS's Institute with global headquarters in Cary.
Great, thank you. And Representative Baker?
Good morning. Hi. Thank you so much. Thank you all for being here and for including me. And so I'm Kristen Baker, and I was just elected to my first term. I was appointed by the governor to fill Representative Johnson's last term of the short session. But so this is my first full term. And I'm grateful to be here. I am a child psychiatrist from Concord, and my husband's actually a radiologist here. We've been here for over 25 years, and I've worked in the private sector, but then also worked with PBH, which then joined with Cardinal. So I've had both the private and the public experience. So really look forward to working on how we can get patients the help that they need. Thank you so much.
Thank you. And Representative Bell. Still on and not on mute. Okay, maybe we'll come back to Representative John Bell. Senator Bergen.
Good morning. I'm Jim Bergen. I'm starting my second term. I've been in the insurance business and health insurance business for 31 years, served on the hospital board for 15 years with mental health, served on the SHIC, and I'm interested in all things healthcare, especially mental health, with all the things we've been facing. And I'm happy to be here this morning.
Thank you. And Representative Cunningham.
Good morning. I'm beginning my fifth term. I'm a nurse by profession who started out as a LPN, went back, got my associates, and later earned my Bachelor of Science degree from Winston-Salem State University. I've practiced for over 35 years in multiple disciplines, hands-on, and I still enjoy what nurses do, and would love one day to go back and do it. I'm just not sure when that's going to be. Thank you for making me a part of this.
Well, thank you. And Senator Heisey.
Thank you. Ralph Heiss, the North Carolina Senate, represent Madison, Yancey, Mitchell, McDowell, Rutherford, and Polk counties in Western North Carolina. This is going into, I've served now for 10 years in the Senate and have chaired health policy and appropriations for health and human services for 6 of those years.
Thank you very much. Senator Krolik.
Couldn't unmute myself. Good morning. Thank you. And thank you, Duke Margolis, for hosting us. We appreciate it very much. I am Joyce Kravick. I represent District 31 in the North Carolina Senate, which encompasses Forsyth County and Davie County. And I chair the Health Committee in the Senate and several other health committees. So proud to be with you, and thank you all very much.
Thank you. And Representative Lambeth.
Good morning. I'm Donnie Lambeth, and I represent Forsyth County District 75. I'm a former hospital administrator, CEO of a medical center, as well as 2 rural hospitals. Most of my career was a chief financial officer. I have an MBA from Wake Forest, and obviously a lot of work I've done in the General Assembly has been around health, as well as appropriations and finance. So I'm also glad to participate.
Great. And Senator Robinson.
Good morning to all, and thank you for allowing me to be with you. I'm Senator Gladys Robinson, representing Guilford County. I'm going into my 6th term in the General Assembly. I've been a community health executive for about 35 years, serving health disparities all the way from sickle cell, HIV, diabetes, and chaired the first board of Health Serve Medical Center in Greensboro, which was for underserved and underrepresented people. So you can see that my interest is deeply in the healthcare area. So thank you for allowing me to participate.
Great, thank you. And Representative White.
Good morning. It's an honor to be here today and to have been appointed, I guess, to this council. I think everybody probably feels the same way that I do. This is an exciting morning. Governor, thank you so much for having this idea. Appreciate Dr. Cohen supporting that. And also thank you so much to Duke for coordinating all of this. You've taken on a huge job. I am a registered nurse. I have practiced it seems like my whole life, predominantly in public health, home care, home health, was a statewide HIV/AIDS nurse consultant for the Division of Public Health, and left the Division of Aging and Adult Services to come to the North Carolina House 4 years ago. So I'll be starting my third term. I currently chair Health and Human Services Appropriations. I was on the school board for 12 years prior to that, so got a little bit of that pre-K and K through 12 experience as well. So it's an honor to be here among such elite folks today, and I look forward to working with you.
Thanks so much. And Senator Woodward.
Good morning. I'm Mike Woodard. I represent Senate District 22, which comprises Durham, Granville, and Person counties. I was just reelected to my 5th term in the state Senate. I'd like to thank Governor Cooper and Secretary Cohen for asking me to serve on this council. And I'd like to thank Dr. McClellan, who's a constituent of mine, by the way.
That's right.
and the team at the Margolis Center for helping facilitate this important work. I'm so happy to see so many of my great colleagues I work with on healthcare and other issues, and those folks from the private sector. I think we've got an important task ahead of us, and I look forward to. I've rolled up my sleeves today. I want y'all to see so we can get to work on this. So thank you, Dr. McClellan.
Thanks so much, Senator Woodard. Now, did I miss any of our legislator leaders who are joining us today?
This is Representative John Bell. I had a little technical difficulty there. And I'm glad to be with you this morning. I represent House District 10, which is Greene, Wayne, and Johnston counties. Served 5 terms in the General Assembly and as the House Majority Leader. So good morning to everybody.
Good morning, and thank you for being here. And now I'd like to turn to our community leaders, and starting with Chip Baggett.
Good morning, I'm Chip Baggett. I'm the CEO for the North Carolina Medical Society, which is the oldest professional association in the state of North Carolina, with more than 10,000 physicians and physician assistant members. Thank you for inviting us to be a part of this.
Thank you. And James Brigman.
I'd like to thank you for allowing me to be a part of this council. I'm a pastor of St. Paul United Methodist Church, which is in Richmond County, North Carolina. I serve a lot of, in the area I serve, there's a lot of poor rural area. I'm also a small business owner, me and my wife, and I also have a daughter that is medically fragile. She's on the CAP-C Medicaid waiver program in North Carolina. And I got involved with healthcare after she was born, and several years ago in 2017 when I walked to Washington. And I've been working up there with different representatives, senators, and congressmen offices since then.
Great. Thanks so much, Pastor. And next is Cassandra Brooks.
Good morning. I'm Cassandra Brooks. I operate Little Believers Academy. We have 2 locations in rural Johnston County and as well as in Wake County. Just excited to be a part of this healthcare committee. Lost 2 teachers who had the lack of health coverage. So I've been in the fight ever since to help expand Medicaid. I see my families, I serve a lot of low income population, and I see the needs that they have as well. So I'm committed to this task. Thank you for having me.
Thank you. And Casey Cooper.
Thank you and good morning. I'm Casey Cooper, the CEO of the Cherokee Indian Hospital Authority, a public health authority that was created as a tribal subunit of the Eastern Band of the Cherokee Indians. I've been the CEO there for about 18 years now, and before that was involved in public health policy as the former executive director for health programs, and then before that worked as a nurse in a number of different areas. Medicaid expansion is very critical to Indian country and is absolutely essential to sustainability of our health system. And I am so honored to be here. Thank you.
Thank you. And next, Andy Ellen.
Thank you very much. And thank you, Governor Cooper and Secretary Cohen for asking me to serve on this committee. I'm Andy Owen. I'm President and General Counsel of the North Carolina Retail Merchants Association. We have about 2,500 members representing about 25,000 store locations throughout the state of North Carolina, both large and small. And I also do a lot of work with the pharmacies. So that's my healthcare sort of background, I guess. But I appreciate it very much. Healthcare costs are certainly one of the thing we hear most about from our members of reaching out and trying to find affordable health care for their employees. So thank you very much. I look forward to the conversation.
Great. Thank you. And next, Don Flo.
Good morning. I own and operate 44 automobile franchises in 10 cities. And with nearly 2,000 employees, I get up every day thinking about healthcare. I've also had the privilege of chairing Wake Forest Baptist Medical Center and also working closely with Donnie Lambeth along the way with that. And now I'll be serving on the board of the new Atrium relationship we have. Also serve as the vice chair of Golden Leaf Foundation, where I get to see regularly and up close the tremendous needs we have for healthcare access in rural North Carolina. And lastly, I've been heavily involved in working for healthcare access in urban settings, particularly to address both the racial disparities and the need for healthcare access to ensure social and economic mobility. It's a privilege to be part of this. Thank you.
Thank you. And next, I think I have Tina Gordon.
Good morning, everyone. I'm Tina Gordon. I'm the CEO of the North Carolina Nurses Association. We appreciate the invitation to participate with this group. I represent registered nurses in the state. We have about 142,000 registered nurses, which makes up the largest segment of our healthcare workforce. So it's great to be with you.
Thanks. And Lisa Harrison.
Good morning. It's so nice to be with you all. I'm gonna try to start my video there. Thank you so much for including local public health as part of this council. It's wonderful to learn together to try to figure out how we journey through this pandemic and get to the other side well and covering as many North Carolinians as possible. I'm in a local health department as the health director in Granville-Vance Public Health, which is a district health department. In more poor and rural areas of our state, we often have districts that work together to leverage resources across county lines. We have an amazing staff of 82 individuals, 22 of whom are now on our communicable disease team. Across North Carolina, we have a local health department in every single county responding, doing testing, contact tracing, case investigation, and inordinate amounts of data management right now. We have approximately 10,000 individuals working in local health departments across our state, and we try very hard to promote health and prevent disease even now. So thank you for this opportunity to work together, and we'll look forward to our meetings. Thanks.
Thanks. And Reg Henderson.
Yes, good morning, everyone. I'm Reg Henderson. I'm Vice President of Government Affairs for Lowe's Home Improvement. First of all, thank you, Governor, for putting together this council to talk about this critical issue. And it is an honor and a privilege for me to be a part of that conversation. This issue is very important for Lowe's for many reasons. First of all, Lowe's is our home state. We were founded here. It is still home. And we put our associates, our communities, and our vendor supplier ecosystem first. And we have 30,000 employees in this state. And we have, many vendors, suppliers, contractors, installers, small businesses in that ecosystem. And we realize that in order for North Carolina to be healthy is that whole ecosystem has to be healthy. So just thank you for being a part of this conversation and looking forward to serving.
Thank you. And Vivian Howard.
Hi, I'm Vivian Howard, and I'm a chef, restaurateur who lives in rural Eastern North Carolina. I've been in the restaurant business here for about 14 years. It feels like 1400 right now. But I'm so grateful to be a part of this.
All right, and Steve Lawler.
Hey, good morning. This is Steve Lawler. I'm the president and CEO of the North Carolina Healthcare Association. Eastern North Carolina native. Before that, I spent 30 years, supporting and leading hospitals and health systems, primarily in the East. I had an opportunity to work with Mr. Woods as well, and just happy to be part of a group of people that care about North Carolina. And then a special hello to my friend, Representative Adcock, who was my mother's favorite graduate student.
And Dr. Mankad?
Hi, Mehul Mankad, Chief Medical Officer of Alliance Health. We manage the mental health Medicaid benefit in and around the Triangle. I'm also a psychiatrist like Dr. Baker, and continue to work in an emergency room and can speak to the emergency department boarding crisis if that comes up.
Thank you. And Dr. McNeil-Trice?
Hi, my name is Dr. Kenya McNeil-Trice. I'm a professor in the Department of Pediatrics at the University of North Carolina School of Medicine. I serve as the residency program director and the vice chair of education here, and will actually be transitioning to the role of chief graduate medical education officer for UNC hospitals in January. I'm a pediatric hospitalist and have been so for several decades, and I'm currently the vice president and president-elect for the North Carolina Pediatric Society. Have been on that executive committee for over a decade, and incredibly excited to advocate for the children and families of North Carolina, given the children are make up the majority of patients on Medicaid in North Carolina, and being a frontline provider in the hospital setting here at UNC, serving all 100 counties and having cared for families, especially children with COVID within just this past couple months. I'm honored and excited to be on this committee.
Great, thank you. And Dr. Newton?
Hey, I had to get unmuted. My name is Dr. Tommy Newton. I'm a practicing family physician from Clinton in rural Eastern North Carolina. I've been there practiced there for 37 years, and I'm representing all family physicians across the state. I've been a past president of the North Carolina Academy of Family Physicians, and also way back in the mid-1990s, I served on Governor Hunt's Healthcare Reform Commission. Thank you.
And Lynn Pierce? Right, Lynn may be having a little trouble there. Gary Salamito. Gary, I think you're on mute somewhere. Not hearing you. Okay, well, I know Gary well from his work leading the North Carolina Chamber and deep involvement in healthcare. Gary, let's try to get your audio back on. Next, I think, is Dr. Seshul.
Good morning. My name is Merritt Seshul, and I'm very pleased to be here. Thank you to Governor Cooper and Secretary Cohen for arranging this. I serve on the board of directors for the North Carolina Medical Society. I am an otolaryngologist, head and neck surgeon that practiced vigorously for 20 years with academic appointments at both UNC and Wake Forest Baptist Health, and currently serve as a regional medical director for a subsidiary of United Health Group called Optum. So I'm very pleased to be here and participate, and thank you.
Thank you. And next, Erica Smith. And Erica, you're on mute as well.
Thank you. I'm sorry about that. Good morning. I'm Erica Palmer-Smith, and I'm the Director of Care for Carolina. We are a coalition of over 80 organizations from across the state that have come together with the sole focus of helping to close the health insurance coverage gap. Our members include patient advocacy organizations, health providers, economic development organizations, and child and family advocates. In addition, we represent the support of over 200 business, civic, and faith leaders across our state, and recently launched a business advisory council spearheaded by Patrick Woody of the Rural Center. We are so appreciative to be a part of this conversation, and Governor and others, I thank you so much for providing this opportunity.
Thank you. And Dr. Satunde.
Good morning. I'm Tunde Satunde, and I had the privilege of taking over the helm as the CEO of Blue Cross Blue Shield of North Carolina approximately 6 months ago, in the midst of the pandemic, no less. I am a physician, a pediatrician by training, though I have spent the last 21 years of my career primarily on the health insurance, health benefits part of the healthcare delivery system. I personally have a passion for helping those that need help the most. And I'm extremely excited and actually honored and privileged to be part of these efforts to not only find ways in which we can ensure coverage for all North Carolinians, but to Dr. Mandy Cohen's points earlier on, also ensure equitable access to care for all North Carolinians. So thanks for having me.
Great, thanks, Tunde. And next, Dale Wiggins.
Okay, hey, I'm Dale Wiggins. I'm County Commissioner in Graham County. Don't know why my camera's not working, but that's okay. I don't have to be singing, but I'm like everybody else. I do want to be heard. I'm in my 12th year as County Commissioner here. I've got a couple years left on my current term. I've worked in state, local government since 1986 in one form or another. 14 years of that in Region A as a CDBG housing specialist, a job that reminded me every day that poverty is alive and well in rural Western North Carolina. I'm very passionate about the region and the people and their needs, and I'm very appreciative to be a part of this council. I hope that we can be very productive, and I hope that we will each hear each other. We all have distinct needs, desires, but our priority should always be the people that we serve. And I'm very grateful to Governor Cooper for organizing this meeting.
Thanks, Dale. Next, Margaret Weller-Stargell.
Yes, good morning. My name is Margaret Weller-Stargell, and I am the president and CEO of Coastal Horizons, which is a private provider in Wilmington, based in Wilmington, serving 57 counties. We are a 50-year organization with over 600 employees who work daily to address the needs of those who have behavioral health and primary care issues. Certainly, I join others in the concern for parity with private insurance, and also to note that those who have substance use disorders, many fall into the Medicaid gap. So I hope that that is an area that we can discuss with this council. And I do want to join others in saying thank you to Governor Cooper and to Secretary Cohen for the opportunity to serve on this council.
Thank you. And next, Patrick Woody.
Good morning, everyone. It's an honor to be a part of this council, and being the president of the North Carolina Rural Center, we really applaud the creation of this council and look forward to working with it. My name is Patrick Woody. In addition to being president of the North Carolina Rural Center, I'm a native of Allegheny County, and my hometown is Sparta, and Reg Henderson will be glad and will know that Sparta was the location of the first Lowe's Hardware outside of Wilkes County, one of our legacies there. For more than 3 decades, the Rural Center has really been dedicated exclusively to rural North Carolina, to improving the quality of life of the people who live in rural North Carolina and the communities that they call home. We know as an economic development organization that the presence of a strong, robust, and viable, sustainable healthcare delivery system is absolutely foundational to the economic health of a community and the people that live in that community. This is an incredibly important issue to us and is one of the top challenges that faces rural North Carolina. We are also proud at the Rural Center to be a member of the Care for Carolinas Coalition and to be the fiscal host of that coalition. We look forward to working with every single one of you.
Great, thank you. I'd like to turn to Gene Woods now.
Good morning. My name is Gene Woods, the CEO of what I like to call the new atrium, together with our family members in Winston and Wake Forest, including Don Flo. We have 40 hospitals, both in urban and rural areas, and about 1,000 care sites throughout the state and beyond, about 70,000 healthcare workers. I do want to say thank you, Governor, for starting off your comments by recognizing the frontline workers who've been, in this from the very beginning. Representative White and Cunningham, if you ever want to get back into nursing, I hope I'm your first call. We could use you. Also the former chair of the American Hospital Association in 2017, expanding coverage was the #1 priority, remains the #1 priority at a national level, and equity of care and reducing or eliminating disparities has been what I would say my life's work in this profession. I also would highlight behavioral health, and it'll be good to get back to that because I think that's a real, we can't do Medicaid coverage or we can't do population health without behavioral health as the core. I also just want to say I appreciate the partnership from Secretary Cohen from the very beginning. I think we're on speed dial on most weeks, and that partnership has been really instrumental to making sure that we're fighting this virus back. And I'm just honored to be part of this group.
Gene, thank you. Next, I think Lynn Pierce, I think we've got you connected now.
Thank you. My name is Lynn Pierce, and I am from Saxby-Hall, North Carolina. For over 16 years, I ran a non-hospital medical detox and facility health, mental health crisis facility, mainly with people that did not have insurance. And for the last 5 years, I have been the executive director of the Safe Food Ministry in Southern Alamance for the largest rural food pantry. So lack of health care, and especially COVID during this time, is extremely important to us. And I appreciate the invite to be a panelist. And I look forward to working with all of you and learning about how we can help North Carolina even more.
Thanks, Lynn. And Gary Salamito. Gary, I think we got your sound working. Maybe not. Well, look, I really appreciate the effort, so we'll keep trying. I know Gary has a lot to add to this group too. Well, what a distinguished group, and again, thank you all for taking the time to be with us and to be part of this effort. Again, we're not coming into this with any preconceived notions for what should come out. We are coming in with a firm belief that by working together, we can make progress. And you've heard a wide range of perspectives are going to be part of this effort. If you have any other thoughts or ideas about making sure we're getting in the best efforts to make progress on access to care and coverage, please let me know, let our group know, and we want to make this succeed. Today, aside from just introducing everyone and hearing some of their initial perspectives on this work, we wanted to start rolling up sleeves, and we're going to do that with a few presentations to help level set where we are. We, again, want to hear from you about other ideas and approaches that you'd like to make sure get considered as part of this process. We're going to have some time for discussion along the way too, today and in the upcoming meetings for the groups. I'm going to turn this meeting over now to Hamie Tourson to lead us through those steps. And just a brief introduction to Hamie. She is currently a visiting senior policy fellow at Duke, at the Duke Margolis Center. A number of you may know her from her previous role directing the health division of the National Governors Association Center for Best Practices. As you know, NGA is a bipartisan effort. It's the main representation of states leadership to the federal government, and a very important group at any time. But one of the things that we found at Duke Margolis in all of our work in the context of the pandemic is that state leadership and collaboration within states is just so fundamentally important to making progress, especially right now as we're in a public health emergency. In that context, we have substantially expanded our work to support state efforts at Duke Margolis, and Hamie is leading that now with a rapidly growing team on issues ranging from vaccination policies and strategies, distribution implementation, to, I mentioned testing approaches before, a lot of things that matter for the pandemic, but also looking ahead, states are going to be really important in where we go from here in terms of coverage and innovation in healthcare. And so we are very pleased that she's here, and we are again making a big commitment at Duke Margolis to try to make efforts like this one right here at home succeed. So Hammy, let me turn this over to you now for the next part of our meeting.
Thank you so much, Mark, and thank you, Governor Cooper and Secretary Cohen. Well, we are going to get right to it. It's really been really a privilege to be working with all of you. And one of the things I wanted to just mention is, this work is difficult, but I think with this amazing group of folks, with all these different perspectives, you all are going to make progress. Certainly when I was at the National Governors Association, I worked with a bipartisan group of governors, as well as legislators and stakeholders, to really find different ways to think about coverage in the context of broader change to their healthcare systems. And so really look forward to the work that we're going to do today. And I love the comments about we're rolling up our sleeves, because that's exactly what we're going to do today as a group. So just a quick outline of what we're going to cover today. We are going to have 3 presentations. You're going to hear from me very briefly with a broad national overview of what's happening with Medicaid as a program and some of the different outcomes we've seen from states that have expanded Medicaid. Then we're going to have a presentation that really focuses on North Carolina. What is some new data that the state would like to present, along with the Sheff Center, that they've really identified in terms of what's happening now in North Carolina with people who are uninsured. And then we're going to move to a third presentation where we'll hear from Greg Moody from the state, who represented Governor Kasich in the efforts to expand Medicaid in Ohio. And Greg will have a lot to share about what his experience was during that time and what Ohio has experienced since they have expanded Medicaid. So with that, I think we can just get started. A couple of logistics just to make sure we can cover it. You are clearly experts on Zoom. I wish we could all be in a room together, but we have to make do with what we can in the pandemic. And you have effectively been able to mute and unmute and go on camera and off camera. So to the extent you're able to stay on camera when we have discussion, that would be fantastic. But understand that that may not always be the case. Also, if you could remain on mute if you're not speaking, that really helps for background noise. The other thing I wanted to mention is we do want to make this as interactive as possible. Again, I wish we could all be in person, but since we're on Zoom, please go ahead and chat your questions as the presentations are going, so we can make sure we circle back to anything you want to hear more about. We also will pause periodically during the presentations to make sure you have time to to ask questions. And if you want to raise your hand so I can just be sure to see who might be wanting to jump in, please do so. The other thing I wanted to mention is we are live streaming, so welcome to the public who is listening into this. We will be posting the agenda, the participant list, and the meeting materials, the presentations on the Duke Margolis website after the conclusion of this meeting. So you will be able to access those materials when we conclude. We also will have a recording of this meeting, so if there's anyone else who would like to hear what we say today, that will be available on the Duke Margolis website. Okay, great. I think with that, I will go ahead and get started. So we are going to talk about Medicaid. Next slide, please. Okay, so just a snapshot of health insurance coverage. As you can see from this slide, health insurance coverage is predominantly employer-based insurance. 56% across the country remain in employer-sponsored insurance. Medicare is second, where people, they're 18% of the population enrolled in Medicare, but Medicaid is right behind that at 17%, following by the individual market and the uninsured. And I just wanted to show this picture to put context of, these are all the different forms of insurance that people have across the country. And we are still a country that relies on employer-sponsored insurance to the great extent, but there are still a bunch of uninsured folks. And you will see my later slides, those numbers are higher in states that have not expanded Medicaid. Who does Medicaid cover? So just a quick review on the different groups that Medicaid covers. States are required to cover certain populations in Medicaid: low-income children, low-income pregnant women, families who have qualified under the 1996 Aid to Families with Dependent Children, which is a small number of families, the age, blind, and disabled who qualify for Social Security income, and low-income beneficiaries who are both eligible for Medicare and Medicaid, and through Medicaid get help paying for some of their Medicare cost sharing, et cetera. There is optional groups who states can decide to cover, and many states do cover these individuals. There's children and pregnant women who are at slightly higher income levels than what is required for states to cover, and many states, including North Carolina, cover some of those folks. There's the medically needy, individuals who may not otherwise qualify based on their income alone, but can spend down their assets in order to qualify for Medicaid. And then, of course, there's a group that we're going to talk about today quite a bit, the Medicaid expansion, where states can opt to cover adults with income up to 138 of the federal poverty level. So I wanted to talk a little bit more at a high level about who is covered under Medicaid expansion. There are primarily two groups that qualify, and when we get to the North Carolina presentation, you're going to hear a little bit more data specifically about how this looks in North Carolina. But at a snapshot at a national level, there's low-income parents above current coverage levels, and their income is still pretty low. It's $2,498 per month for a family of three. So I wanted to just give you that stat so you can understand, the level that we're talking about in terms of who would qualify under this program. And there's also low-income childless adults with income less than $1,436 per month for a single adult. And who are those individuals? So underneath those two big buckets, we just highlighted a couple of types of folks that would qualify. These are low-wage workers in agricultural jobs, childcare, construction, et cetera, veterans and their families, children who age out of Medicaid, and women who would be covered if they were pregnant, but they are no longer eligible because they're not pregnant. So just to give you a sense of who these people are. And again, when we get to North Carolina presentations, you'll hear a little bit more specificity about how this is looking in North Carolina. Next slide, please. Also wanted to talk a little bit about the Medicaid expansion population and what their dynamics are with respect to working. So this is a survey and study that was done by the Kaiser Family Foundation, and their data shows that if you really look at who is eligible for Medicaid expansion, 63% on a national level are working in some sort of job. And that's because they have jobs that do not offer them insurance. And we saw on the first slide, we still are a country where a lot of people have insurance through their employer. Not everybody does. And so some of those folks are on the Medicaid program and specifically under the Medicaid expansion programs in different states. Other reasons why they're not working and they're covered by Medicaid, it's because they're retired, their inability to find work or other reason. They're not working because they're in school. They're not working due to an illness or disability, or they're not working due to caregiving. So just wanted to give you a snapshot of that. And when we get to the North Carolina slide, you'll see a little bit more about how that looks in North Carolina. Next slide, please. I want to talk a little bit also about Medicaid managed care. North Carolina is a state with a lot of exciting developments. You all are going to move to comprehensive managed care in your Medicaid program, and across the state, you're following the trend of many, many other states. 81% of the Medicaid population nationwide is enrolled in managed care, and 47 states enroll 50% or more of their Medicaid population in managed care. And the reason I wanted to highlight this for you all is when we look very carefully at the Medicaid expansion population, it's about 90% of that population that's enrolled in managed care across the country. So the predominant majority of folks that are enrolled in expansion are in managed care plans, and North Carolina would also follow that suit if you all were to decide to expand Medicaid, because you're going to be rolling out your exciting new managed care program in the coming months. Okay, next slide, please. Wanted to just talk briefly about what do people think about Medicaid, and it's interesting. In 2017, when there was a lot of discussion about changes to Medicaid at the federal level, the public, I think, learned more about the Medicaid program and what it means. And if you look at these stats here, again, from the Kaiser Family Foundation, overall, about 75% of people in the US have either a very favorable or somewhat favorable opinion of Medicaid. And I really love this slide because back when I started doing health law in the late 90s, people confused Medicare and Medicaid. They didn't really know what the Medicaid program was. I think we've come a long way since that time, where people have a true understanding of what Medicaid is and what it can serve in terms of coverage. So wanted to just show you this as I think this rings true for people understanding more about it and appreciating the program. Okay, let's talk a little bit about Medicaid expansion. Where are we? Which states have expanded and which states have not? I think this map will show you that since 2014, 38 states and the District of Columbia have adopted Medicaid expansion, and states continue to shape their programs. And to date, no one has stopped expanding. So once they've expanded, they've remained expanded. A couple of things just to note, it's in the light purple. Missouri voters have approved a ballot measure in August 2020, but they haven't expanded yet. Coverage will begin on July 1, 2021. And then in Oklahoma, the voters approved a ballot measure in June 2020, and coverage will begin in July 2021. So they will be fully purple shortly, but not quite yet. Okay, so I wanted to talk a little bit about the uninsured. So, as you saw on that map, not all states have expanded Medicaid, including North Carolina. And here's just at a national level, some data on the uninsurance rate. So you can see here for the United States overall, we are at 10.9% of uninsured, and that has dropped from 2013 quite a bit, from 16.7%. In expansion states, that's dropped even more. On average, they're down to 8.5% for uninsured. In contrast, states that have not expanded Medicaid, including North Carolina, they're at 13.8%. So quite a bit of difference between states that have expanded and states that have not in terms of how many uninsured people you have in your state. And when we get to the North Carolina discussion, Mark from the Shep Center is going to drill down a little bit more on what that looks like in North Carolina. So again, here, just to show this more graphically across the states, you can see where there's green, where there's a lot higher uninsured rates among the non-elderly as of 2019, and North Carolina is certainly in that group, which includes states that have not expanded Medicaid. Although there are a few states that have that are still remain in that group. And what does it mean to be uninsured? What are some of the challenges that are associated with being uninsured? And I thought this graphic helped explain some of that and what that means. I think we all on the phone know a lot about this already, but thought it would be helpful to review. So if you just look at the stats here, if you compare the uninsured to those who are insured, 41.5% opted not to see a doctor or healthcare professional, compared to 11.9% who are on Medicaid. Or 14.6% who had employer-sponsored insurance. Quite a big difference, as one might expect. They did not have a usual source of care, which really impacts the ability to receive preventive services for major health conditions and chronic disease and prevent some of those more serious events that could come after the fact. So you look here again, 40.8% who were uninsured did not have a usual source of care compared to a lot lower numbers for Medicaid and employer-sponsored insurance. Postponed seeking care due to cost. This is an important one because when you postpone a medical need, that often results in needing emergency care or more serious hospitalization. So you can see here, 32.1% who are uninsured postponed care compared to a lot lower rates with respect to Medicaid and employer-sponsored insurance. And again, same thing went without needed care due to cost and delayed filling or did not get needed prescription drugs due to cost. So just wanted to show this graphically that, insurance matters. Healthcare in our country is expensive. And if you don't have coverage, you're going to make different choices. So I think this really illustrates the point of why insurance can be really helpful to making sure people are healthy. I would also note, I'm going to talk about COVID-19 at the end. This is also true in the context of COVID-19. Really, having people get the care they need so they can be healthy, to do their jobs, to care for their children, to do whatever else they're doing in their lifetime, I think is really important. Okay, what do we know about Medicaid expansion cost projections? So one of the things I wanted to share, and I think Greg's presentation in Ohio will help explain this a little bit more in very practical sense about what they saw in Ohio. But states have gotten a lot better about predicting how much Medicaid expansion is going to cost. So if you look at why that is, before 2014, there wasn't a lot of data on who these populations were going to represent, what kind of services they were going to use. But now there really is a lot more data given all the years other states have had to really experience Medicaid. So, we know more about their health status, we know more about how they're going to use services. We know more predictable data about enrollment and take-up rate, and we know about Medicaid and non-Medicaid state program savings. So I think with all of these different data points, it helps states who have not yet expanded Medicaid have a better sense of what is this going to cost. And so when we get to the North Carolina presentation and the Ohio presentation, I think you'll see, especially with respect to Ohio, how that played out with respect to their projections and then realities of after they expanded Medicaid. Also want to just spend a moment talking about, okay, for states that have expanded, where do they continue to spend their money in the Medicaid program? And I wanted to show this because I thought it was helpful to see when you expand Medicaid, you're going to have more adults on your program, and you'll see, adults are 40% of the population. Children continue to be a big part at 39% at a national rate. But states are still spending more on the disabled and the elderly. So you can see here, even though, elderly is only 9% of a Medicaid population, there's still 19% of the spending because of the need for long-term care services and more complex health needs. And the same is true for the disabled. So I wanted to show this because I think states, who hadn't expanded yet had some concerns about, well, if we expand Medicaid, are we going to spend a lot more on that population versus, those who are disabled or elderly or children? And it actually ends up, at least at a national snapshot, not being the case. And I think, when we get to the presentation about Ohio, Greg can explain that as well, about how that played out in Ohio. Okay, and how have states paid for expansion? So, as we all know, the federal government will pay 90% of the cost of Medicaid expansion, and states will have to come up with that 10% for the non-federal share. And of that 10%, these are the ways that states have decided to finance this. And, we all know this is a difficult time for state budgets, and creativity is needed in terms of, much more limited state general revenue. So other states have faced similar challenges, and they've used provider taxes and fees, primarily hospital taxes and fees and health plan taxes. So that has been a big way that states have decided to expand to finance that 10% that they have to provide to pay for Medicaid expansion. But there have been other ways that states have been creative about how to pay for that 10%. They've used Medicaid and other state program savings, state general funds, and other taxes and local sources, which for some states like Indiana had a cigarette tax and Kentucky had an increase in drug rebates, et cetera. So, but I do have to say at the top line, the provider taxes, especially in the beginning years, was really a way that states were able to pay for their share after the federal government no longer paid 100% of the match for the Medicaid expansion population. Okay, just wanted to quickly review some of the data that has been identified in terms of impacts of Medicaid expansion. The first one I wanted to talk about is improving access. So studies have shown that Medicaid expansion has resulted in significant coverage gains among low-income and vulnerable populations and reductions in disparities. And I think you saw from my earlier slide just the rate of the uninsured, which really supports that. But there have been more systematic studies that have actually showed there's also been a reduction in disparities. Several studies have also shown coverage gains for low-income workers and individuals with mental illness and substance use disorders. And I'll have a slide later. Medicaid has really played a role in providing access to mental health services for the expansion population that they did not have before the state expanded. Access to care. So multiple studies have demonstrated increased utilization of preventive care for a range of conditions, including cancer, diabetes, behavioral health, and heart disease. And I think if you remember my slides earlier, where people, when they didn't have insurance, they just didn't want to go, right? There was a lot higher percentage of they didn't seek care, they didn't have a usual source of care. So when you provide them with that access to care, this is what happens. One study also found an increases in primary care appointment availability, and another found an increase in providers accepting new patients. Many studies conclude that providers have expanded capacity or participation in Medicaid. And that's a point I think of, like, there has been investments in networks and actually expanding those networks. And I think Greg is going to talk a little bit about that in what they saw in Ohio, where they had more provider participation, they had more capacity for behavioral health services, for example, because of Medicaid expansion. And national studies have also shown reductions in marketplace premiums in expansion states compared to non-expansion states because of the additional ability for access through Medicaid coverage. In terms of affordability, Multiple studies have shown large declines in out-of-pocket costs, delays in seeking care due to cost, medical debt, and disparities in affordability. So again, you know, we all know healthcare costs a lot in our country, and providing Medicaid coverage for those who need it for whatever time period they need it can really help with them being able to seek care and afford it. They also have noted that Medicaid expansion has resulted in significant declines in uncompensated care for hospitals, clinics, and other providers, because there is another source of coverage for folks who may not otherwise have access to care. Okay, next slide, please. Health outcomes. So a couple things that studies have shown in terms of how have people reacted to Medicaid expansion. Many studies have shown increases in self-reported health and positive health behaviors. Studies have found associations with reductions in mortality at the population level and for particular health conditions, such as cardiovascular disease and end-stage renal disease. Low-income individuals in Kentucky and Arkansas reported a 23 percentage point increase in excellent self-reported health from 2013 to 2016. And mean infant mortality rates declined in Medicaid expansion states, but rose slightly in non-expansion states from 2014 to 2016. In terms of behavioral health, I wanted to just be sure to highlight a few things here. There's improvements in self-reported mental health. A 2020 study found that expansion was associated with a 6% lower rate of opioid overdose deaths. And there were improvements in access to medications and services for treatment of mental health and substance use disorder. Kentucky, for example, saw 300 new behavioral health providers enroll with Medicaid in 2014 and provide substance use disorder services to 13,000 members. So obviously Medicaid expansion playing an important role for behavioral health. And then next slide, please. Just wanted to talk briefly about the economy. So the labor market, and I'll let Greg talk about Ohio. I'm just skip that one. But for in other states, Colorado, Medicaid expansion created 31,000 and change additional jobs, 39,000 jobs in Michigan, 40,000 jobs in Kentucky. So just to give you a sense of the ability of Medicaid expansion to actually impact the labor market, I think is important. Economic growth. Expansion has certainly been associated with decreases in poverty rates and food insecurity. Pennsylvania saw a $2.2 billion increase in economic output and a $53.4 million increase in state tax revenue. And a 2017 study saw Medicaid expansion found personal income increased by more than $2 billion per year, yielding over $145 million in new state tax revenue. Now, these stats, of course, are pre-pandemic. But just wanted to give you a sense of how historically Medicaid expansion has impacted both labor market and economic growth and state budgets. Okay, next slide, please. Wanted to just talk briefly about the impact of expansion on rural communities, because that is such an important piece of what you all are going to talk about. So here you can see that expansion has a particularly large impact with respect to increases in coverage, improved operating margins for rural hospitals, and improved hospital financial performance and reductions in rural hospital closures. And I think if you just look alone at, you know, how the numbers of rural hospitals that have closed, you can see for expansion states, they've done a lot better. So just something to note. And then finally, I think I've talked a lot already about how Medicaid expansion can impact substance use disorder and opioid epidemic more broadly, but just wanted to show here graphically that Medicaid is the largest funding source for the treatment of opioid use disorders at a national level. It outpaces all the other insurers just because of the nature of the program. And then just to touch briefly on Medicaid's role in responding to COVID-19, you know, the data shows that Medicaid enrollment is increasing as a result of the pandemic. But what's interesting about this stat is that it's both expansion and non-expansion states that are seeing increase in enrollment. So I just wanted to point this out to show you that it's not just the expansion states that have seen an increase. There is other states on this list that have not yet expanded, including Oklahoma and Missouri. As I mentioned, they're going to expand in 2021, South Carolina, Alabama, and Nebraska. Okay, and then finally, just wanted to talk a little bit about the difference in expansion versus non-expansion states with respect to federal dollars, which is particularly important in the context of the pandemic. So, you know, the CARES Act was stimulus money for the pandemic, as well as, of course, Medicaid money. You can just see expansion states compared to non-expansion states states that have expanded Medicaid will receive an average of $557 more per resident in federal funding compared to non-expansion states. And I just wanted to point that out is because especially with respect to the CARES Act funding, wanting to be able to have flexibility to use funding to address different needs of the pandemic, which we know, testing, contact tracing, vaccine access and distribution, important to know the flexibility that states have had that have expanded Medicaid has been higher. And then finally, wanted to just also show the Medicaid expansion boost coverage for low-income essential workers. So if you look at this chart, you can see the reduction in uninsured rates for essential workers, a lot lower in expansion states. So more essential workers have healthcare coverage in states that have expanded compared to states that have not. I know that was a whirlwind. I wanted to go through that quickly because I wanted to make sure we get to the other speakers. I know there were a couple of chats in the notes in the chat. It doesn't look like there was any questions per se. It was a lot about just comments, except Andy Allen said, is there a breakdown of what industries those jobs were created in? And great question, Andy. When we get to the North Carolina presentation, Mark will go through what that looks like in North Carolina, which I think will be very helpful. So I wanted to pause just for a minute to see if anyone had any burning questions before we moved on to hearing more about North Carolina. Anyone?
Hey, this is Tunde.
Yeah.
Oh, yeah. Great presentation. Just going back to funding mechanisms specific to provider taxes. If I recall, though, in most states, they offset the impact to the providers through raising Medicaid reimbursements and getting, a higher drawdown from the federal match, so something like that.
That is true. There are some states that raised provider payment rates in order to help offset what they would pay in the tax. That is correct. Yes.
And this is Gene, just to piggyback, obviously, healthcare providers have taken a pretty big hit responding to COVID. So I think that's going to be important to make sure we're not disrupting access in a different way by mismatching those resources. The only other comment I'd have, an excellent presentation. And I was on the board, AHA board in 2017 when we were fighting Medicaid and to keep it viable. It'd be good to package this in a way that we begin educating the public. I don't think people really realize that most of those on Medicaid are working or elderly. And if there's a way that we can tangentially with our efforts here, educate the public. There are veterans as well that are getting Medicaid. There's elderly, there's disabled. I think that would be a helpful part of this work going forward.
Great comment, yes. And one of the things we're going to be doing as part of the Duke Margolis work on this project is summarizing what's coming out of these meetings, and we can think about how to make sure we highlight some of those points that you just mentioned in those materials. So, great. Any questions? Okay. All right. Well, thank you for your attention. I'm going to now turn it over to Dave Richard, who many of you know well, who is the Deputy Secretary for North Carolina Medicaid, as well as Mark Holmes, who's the Director of the Cecil G. Shep Center for Health Services Research. And they're going to provide an overview of the North Carolina landscape. So Dave, take it away.
Great. Thank you, Hammy, and for the presentation. And I want to second to thank you all for giving up your time for this work. We think it's very important to have this real dialogue. I'm going to take just a few short minutes to go over just a high level of what North Carolina Medicaid currently looks like today. For those members of the General Assembly, you may want to take your coffee break here because several of you have heard this multiple times. So hopefully it can make it a little bit more interesting here. So if we can go to the next slide, I'd like to do that. We always like to highlight who the people are in a Medicaid program. And I think we know that, and we'll talk a minute about how many of the Medicaid beneficiaries currently are children, but it's a 50-year-old program in North Carolina. Currently, we have about 1.9 million people on the full Medicaid benefit. That goes to about 2.3 million when you think about the other services, but who get full Medicaid in North Carolina. And the truth is, it is birth to death, right? We start with pregnancy. We have children, a large number of children. And as others have mentioned, is that a lot of people with disabilities and older North Carolina citizens and residents who are on the Medicaid program. So it's a wide-ranging program. Why don't we go to the next slide, get a little bit more. Often people talk about the benefits of Medicaid and who can be a part of the Medicaid program. I think it's really important to note, and again, we'll have a couple of slides to show this, is that, to get onto Medicaid in current circumstances, without being one of the specialty populations, you really have to be very poor. If you look at the income levels that people have to be on Medicaid, it is very low. Even as we go up to, our children, still we're at 200% of poverty level for those children that are on there. And then for a lot of our programs that support people with disabilities, there are spend downs that are required in those programs as they go forward. So the program covers a lot of people, but right now in North Carolina, obviously you have to meet one of these categories, but it is certainly not a program for that benefits on a base program people that have a significant amount of income, which goes to why there's I know there's a couple of conversations about, we're having a lot of conversation about Medicaid. Well, I think it's the level setting about what the Medicaid program looks like now, and also what is the potential for using a Medicaid program. But just want to reemphasize that we know that there are other things that we need to talk about, but we want to make sure we have this level set today. If we can go to the next slide, it would be great. I think this slide is one of the more important ones when you start thinking about who are the people in the Medicaid program, and what do we pay for. If you look at it, the largest percentage of people in Medicaid are families in children. And when you look at the 75%, actually 75% of that group are children. So it is a program that we spend, you as policymakers and you as North Carolina taxpayers, and U.S. taxpayers really support children in this program significantly. If you look at the smaller percentages for people with disabilities and older adults, much smaller percentage. But when you map that to the cost of the program and the service expenditures, you begin to see that the expenditures for the program really are heavily weighted toward people with disabilities and those who are older in the state. It's important to think about, if you wind up in a nursing home in North Carolina, eventually Medicaid will be a payer for that for most people that are in that place. If you have a developmental disability or mental health need, most likely Medicaid is going to be a payer for that. So you see these numbers, and the numbers are higher, obviously, for that group because so much of it is long-term care and long-term supports and services. But it is a critical program for people with disabilities and older adults. But the vast majority of people in the program are these are families and children. So we go to the next slide. We like to brag a little bit in Medicaid. We haven't had a chance to have an oversight committee in a while, and for Representative Lambert and Heiss and others, Senator Heiss and others that are on those committees, Senator Krovic, we wanted to let you know that during the pandemic, we did a lot of stuff. And the reason why I wanted to show this slide is not so much as joking about the bragging, but not so much about everything that's happening, but to show that, we are a changing world, right? With COVID has brought a lot of changes to our process. With your support, with the legislative support of our community providers and the agency I work with, we were able to make rapid changes in our telehealth policies and our policies around how we support providers and multiple other things in a Medicaid program. I as a outsider for years of government, I used to think about the Medicaid bureaucracy as slow and lumbering. And sometimes we are, but as the pandemic happened, again, I think we working with our legislative leaders and policymakers were able to make rapid changes in a program to address the needs of North Carolinians. So we're very proud of that, and again, very proud of the cooperation and support that we have with our provider and legislative community. So we can go to the next slide. Again, bragging a little bit, but I want to talk about this because often what we hear from folks that don't know, that they haven't been around a Medicaid program, is what you see in the red in 2011 and 2012. There were years, and I'm not going to tell you that there won't be a year in the future, but there were years where there were significant overruns in the Medicaid program. And those overruns, I believe, had a lot to do with the way that we did forecasting inside of Medicaid. Frankly, some of the ways that we work with the General Assembly in doing appropriations for that. But for the last 7 years, and I think that's a fairly long time, Medicaid program, because of the collaborative work with the General Assembly with our Office of Budget and Management at the state level and our really improved forecasting from the Medicaid team, that we've been able to, at the end of the year, be able to finish in, private sector terms in the black. These dollars wind up, obviously going back to the general fund at the end of this period of time. But there hasn't been that problem where we've had to do additional funding for the Medicaid program because of that collaborative work. And I think that's why, again, we're so believe that it's so important to have this kind of relationship where we are talking about the critical issues about North Carolina with the General Assembly in both parties, so that we make sure that we're doing this kind of work. No one wants a surprise at the end of the fiscal year. And again, very proud that we've all been able to work together, and that hasn't happened. So that, I think, is an important story that we need to make sure people hear. If we go to the next slide, it'd be great. Hammy mentioned earlier that we will be joining much of the rest of the nation in Medicaid and moving to managed care in July of 21. We've had some starts and stops for a lot of different reasons, but I am, again, pleased about the working relationship that we've had with the executive branch, the General Assembly, to come up with a solution to move forward with transformation that passed during the summer. This is how we lay out vision, and it's really important to note is the innovative whole person centered and coordinated system of care that addresses the medical and medical drivers of health. We knew this was important. You all know it's important that we think about health, not just health care. We think obviously coverage is really important to be able to get to health, but we think that the future of our healthcare system and our health system in North Carolina is one in which we'll continue to innovate, as Mark mentioned in the beginning, but innovate around how do we provide the most value for our residents in North Carolina, and one in which we're also providing value for our taxpayers as we move forward. So addressing these issues are so critical as we go forward. And then I will mention just a little bit about a timeline if we go to the next slide, and then close out with that. The mention that we are going live with managed care in 2021. The time we launch on July 1st of 2021 in North Carolina, where the vast majority of Medicaid beneficiaries will be in managed care. We do delay our tailored plans for people that have severe mental health and developmental disabilities, and for another year after that. But the vast majority of people currently served, while at this point, will be in these standard plans at launch then. But I want to be clear to everybody here, right, that although we say we're launching on July 1st, actually the work is in high gear right now. We're committed to that date. We'll hit that launch date. But open enrollment, which is really the start of this effort, begins in March. So we are 4 months away from really the beginning of managed care in North Carolina with that open enrollment process. And this slide just kind of gives you a sense of what the future looks like. It's really, I want to end on this, is that as we talk about Medicaid in North Carolina, again, I think there are a lot of myths that the public has. I think that, again, our members of the General Assembly and provider community know what the real story is about Medicaid and who it serves, how we do it. But I think it's important for people to know this. We are excited about the potential for our launching of managed care because of what it can do for our residents in North Carolina, the changes that we can make around population health, social determinants of health. And as we think about coverage, we're excited about the opportunity to have that conversation with you and think about how that fits in this new managed care environment as we go forward. We think it offers cost predictability, as well as the past that we've had. I think we're in good shape in North Carolina to really make a decision to move forward on increasing coverage for North Carolina residents. So, Hemi, I'll stop there, and if there are any questions, happy to answer those, and or make sure that somebody knows how to answer and can do that.
Yeah, thank you, Dave. And I think we had one from Senator Robinson. The question is, while we have had surplus at year end, how many providers have we lost? And is that due to our low reimbursement rate for Medicaid?
Senator Robinson, a great question. And what I'd say is that we actually haven't lost a lot of providers in North Carolina Medicaid. In fact, I think our team would say we've gained providers. There are cases because of population increases where it may feel that way, and it's not even across the state. One of the things that I'll be most proud of is that we were able to raise rates for our primary care physicians, which included pediatricians 2 years ago, because of the flexibility that the General Assembly allocated to Medicaid to work within available resources. So those rates are now comparable with Medicare, which may not be the greatest rates, but they're certainly better than they were inside of Medicaid. So on that side of the coin, I think we've done a good job of keeping our provider community. I know there are some places where we certainly have to continue to look at that. And I would also add that during COVID, again, with work we were able to do because of the enhanced financial participation by the federal government and support of our General Assembly, and we're able to raise rates for most of our providers to address the COVID issue during that period of time. Those are temporary, but we believe that has allowed us to keep providers inside the system during the COVID pandemic.
Can I follow up real quick and indicate that I know from a lot of minority providers and those in rural areas across the state, those that I know in my area, they have in fact not taken new patients, and their offices are suffering even prior to COVID. Even though our rate went up to the Medicare rate, they're still suffering. So I don't think we need to look over that in terms of projecting or acknowledging the real data.
Senator Robinson, I realized when I was speaking that I should have expected that second follow-up, because you're correct. One of the things we've recognized is that as we've gone through the pandemic, we know it proportionally affects minority communities. We also have seen with I think clearer eyes the lack of minority providers in our system and how we have to recruit to have those providers in there. And I know that we'll be working with you and others throughout the coming years to make sure that we do a better job of that.
Thank you, Dave. Thank you, Senator Robinson. Okay, we're going to transition to Mark Holmes. And just before we did that, I just wanted to mention, we're talking today about Medicaid expansion because it's one of the tools and a significant tool to increasing access to healthcare. But when we get to the after the presentations, I really want to have a discussion with all of you about what else we want to talk about as a group to think about in terms of improving the healthcare for North Carolinians and including access to coverage. So wanted to just make that point clear. And what we're going to do now is I'm going to turn it to Mark Holmes. He's going to talk just about some new data that he's identified with respect to who is uninsured in North Carolina. So Mark, take it away.
Thanks, Amy. So yeah, to that point, this is primarily going to be a data-based presentation. I know that Representative Adcock has seen me present 10, 15 years ago, probably. And the pictures are a little bit prettier than they used to be, but other than that, it's pretty much a data-based kind of presentation. Rebecca, next slide, please. So I think first thing I want to start off is there's three different denominators that we often think about when we think about insurance coverage. There's the total population. Sometimes we just look at the non-elderly because the uninsured rate among 65 and over is less than 1% in North Carolina. Sometimes we focus on 19 to 64, the adult population. And so as you'll see some of these uninsured percentages jump around, we have to pay close attention to who exactly we're talking about in terms of the overall population. So I just want to make that point because that'll be important as we go through. So this is sorry, Rebecca, too fast. So this is an overall picture of how the U.S., North Carolina, and Medicaid expansion states compare in terms of coverage. We see that North Carolina is there in the blue, and that's a compromise between my light blue from up the street and the darker blue from our host today. So I guess that's a political blue there. But you can see that North Carolina has a lower rate of employer-sponsored insurance than national, lower on Medicaid, higher on Medicare, reflecting our little bit older population, and of course higher than in the uninsured in particular. That blue bar compared to the green bar is much higher. Also noteworthy is that higher military function or coverage as well, which is a testament to the importance of the military in our state. All right, next slide, please. Okay, so now we're focusing on the 19 to 64 and same sort of consideration. Again, now because we're just looking at adults, you can see that Medicare percentage is much lower because we're not talking about the elderly. Again, we see same sort of patterns, lower in employer sponsored, lower in Medicaid, higher in the individual market. So these would be both the federal marketplace and the non-group purchases that people have been doing for years in terms of the individual. Again, that uninsured jumping out in the adult relative to everyone else. It's important to note here that these rates are based on pre-pandemic unemployment levels, or more generally the economic nature. This is from 2019. So as the pandemic has affected the economy overall, certainly unemployment, but also in other aspects, the uninsured rate may be higher. And there's a piece in the North Carolina Medical Journal this month that estimates what some of that might look like. And there have been other estimates to look at that increase in the uninsured rate since then. Next slide. All right, so a little, here's some tables to sort of put you in a frame of sort of what we're talking about. We present the income levels in a variety of different ways. Hammy and Dave both talked about presented as a monthly basis. I like to think of it as annual basis. But the 138% that we're talking about as being important and interesting cut point because of its expansion, just to give you a frame, is about 36,000 for a family of 4, just to, again, give you that kind of context. So the blue bars represent the percent in each income category that are uninsured. And perhaps in the most unsurprising slide you'll see all day, the lower your income, the higher your uninsured rate. If you have less than 50% of federal poverty level, then about a quarter of individuals are uninsured, 200% or more, about 8%. So there's a strong income gradient, as you would expect. So also interesting to think about it in the other direction, and that is, of the uninsured, what percent, what is the income breakdown? So this is among each income, what percent are uninsured? About a third of all North Carolina uninsured have income below that 138 level. So that gives you a sense in 2 different ways of the importance of income as we're talking about the uninsurance. Next slide. So this is an access group, not just a coverage group. So we need to think about it in terms of the ability, given that just under 60% of health insurance is through the employer. What does it mean in terms of your ability to have it offered to you, or have access to it through your employer? And the left panel looks at different occupations. The right panel looks at wage. I like to think of the right panel being one of the more interesting in the huge impact of small businesses. Roughly half of people who work in a small firm that is less than 50 workers do not have access to employer health insurance. And so that the size of the employer being a huge determinant of whether you have access to it at work. Of course, that middle panel tells us income is important, and occupation as well being interesting, but that firm size also being a key component. And particularly when you think about rural, that's particularly relevant when you think about the disproportionate number of small employers in rural rather than urban settings. Next slide. Here's a sample of 7 different occupations that are relevant. Most of these, I think, are strongly driven by what we've seen over the last 6 months in terms of a pandemic, 8 months, I guess now. With the uninsurance rates, I'm not going to read through all of these, but you get a sense of the high number of my percentage of uninsured in each of these categories, the average income. So this is a nice slide to think about people who are working in this industry and their annual income, what the uninsurance rate and what the percent looks like in terms of offers. So again, for example, you can see hotel and lodging, 40% are insured through their employer, leaving 28% uninsured. Next slide. A comparison slide here showing percent of uninsured. An earlier one looked at the uninsured compared to expansion states more broadly. Here are 3 states in the South that we can compare it to. You can see from the green, these were the uninsured rates among adults in 2013 prior to expansion. And then we can see the blue, meaning 2017 levels. The three that have expanded have seen larger decreases. Of course, North Carolina has seen a decrease as well, but the expansion states seeing larger decreases. Next slide. This is a fun slide that is sort of like an infographic, and you can work your way left to right, but it breaks out in terms of the age, what percent, or who are the uninsured in terms of age. You can see disproportionate among young adults, nearly a third in that 19 to 30 age category. And as you get older, it's lower uninsurance rates. Among adults, almost 3/4, or I guess just over 3/4 are employed. We've talked about that a little bit as well, and that's a really important component to be thinking about, that many of the, at least eligible for Medicaid expansion group, this would be below the 138%, are working. If you look overall across all categories, it's about 60%. So there is most uninsured in North Carolina are either employed, or if you're a kid, your parent has a job. Race, ethnicity, Hispanic being the most overrepresented group in that category. The blue panel shows that about a third of uninsured adults have children, and that's in their household, and women being slightly more likely to be uninsured. Next slide. We've talked a little bit about the uncompensated care and the role that hospitals are filling because of uninsurance. And I have to count that out, but that's 1.8 billion in uncompensated care in 2019, plus another 1.6 in Medicaid and Medicare. And that losses are the delta, as Senator Robinson pointed out, the delta between Medicare, Medicaid rates and the higher rates that commercial generally pay. So these will be losses associated with those, with accepting those plans. So, but 1.8 in what we would colloquially refer to as charity care, or care that's written off. Next slide. This is a map that shows the percent of the county's population, of the adult population, who are uninsured and under 138. And if you take out the under 138, the map looks strikingly similar. We see the darkest, so darker colors are higher percent. So these are counties where the uninsured rate is higher. We see two pretty marked clusters in the, Duplin, Sampson, Bladen, Robinson area, as well as the Swain, Graham, Macon, sort of far west. So, you can really see the importance of rural, which we've heard multiple times, and the overrepresentation of rural among the uninsured, and how uninsurance is more common in rural settings. Next slide. So a little bit about rural. My day job is at the Shep Center. I spend a lot of time in rural health, so I'm passionate about this in particular. Rural residents are about 40% more likely to be uninsured and eligible. That's based on those slides, and that's 40%, not 40 percentage points. So, just relatively more common. Prior studies have shown that expansion is associated with improved hospital financial performance. Hammy talked about that a little bit as well, and reductions in hospital closure. Across North Carolina, the way that we count, there are 11 rural hospitals that have closed since 2005. Many others have cut services, maternity health being a very visible one, but others as well, surgical care, for example. One of the things that we do is classify rural hospitals based on their financial risk and the likelihood of being in financial distress in the next 2 years. And we identify 6 rural hospitals across the state that are currently in that category. And those hospitals serve about 180,000 people. And those, again, are, because they're rural hospitals, those are rural people. And work we did 15 years ago, so of course it's higher now, but losing the only hospital in a county is associated with a decrease of about $1,300 in per capita income. And I'm going to pause for a moment on that. And that's not, some people lose their job and relocate. That's $1,300 across the entire county population. Why? We know that a hospital is the first or second largest employer in rural counties. We think of it as the amenity effect. And if you're trying to, open up a manufacturing plant, one of your first questions when you're looking at a site is, where's the closest hospital? Because that's going to drive, or at least be a component of your workers' comp rates. And so having a rural hospital is important from an economic development standpoint, not just a health standpoint. Next slide. Veterans, of course, are something we care a lot about in North Carolina, and we have about just over 700,000. I think most people on this call know, but the general public don't always understand that, just because you're a veteran doesn't mean you get care through the VA. And you may remain uninsured if you don't qualify for VA services. So looking at expansion in other states and what's happened to veterans on insurance, Robert Wood Johnson and Urban Institute found about a 4.3 percentage point decline in uninsurance in expansion states. That leads to about 14,000 probably in North Carolina veterans who would gain health coverage. Next slide. Okay, so here's sort of the summary slide. I mean, we've to Hamy's point that we talked about Medicaid expansion a lot today. But I think it's, my goal was to provide some more general data, but I think from the expansion standpoint, we've, those that are, it's not just who would be eligible for Medicaid expansion, but are uninsured regardless, are likely to be younger, working, many for essential industries, and include a lot of families. We saw a third have children in the household. Would help rural residents, and particularly strengthening those hospitals and benefiting those communities. So as someone who thinks about rural, along with Patrick and many others on the call here, understanding the role of uninsurance and ways to decrease that uninsurance rate in rural, we know that that's important from economic viability of rural communities. And roughly 200,000 uninsured employees would gain health insurance if we can help with that, disproportionately among the small firms, disproportionately among rural, but often among statewide. I think that's the last slide, Rebecca. Yes, it is. So I guess I'll pause there, and Amy will tell me what questions I should answer.
Yes, thank you, Mark. That was excellent. We have a couple questions here. Senator Woodard asked, of the 6 hospitals that have high financial risk, how many are independent?
So here's an answer you're not going to like, in that we don't generally reveal anything about who these hospitals are. And that's often because once we say, here's a hospital that's really struggling, that becomes a UNC says this hospital is on its last ropes, and that makes it hard for the hospital to recover from that standpoint. So we're generally quite protective of those data. I will say, how about this if I answer overall nationally, hospitals that are independent are far more likely to be a financial risk. So if you interpolate that down to North Carolina, you would probably be seeing independent hospitals being more likely to be financially distressed.
Thank you. Great. There's a whole bunch of questions coming in. Does Medicaid policy cover telehealth services at parity? And it seems like Sampson Regional Medical Center is one example, but if there are others, that might be a Dave question.
Yeah, I think I probably would refer Dr. Satundi's question to Dave or other ones who can answer from a Medicaid standpoint. And Dr. Newton, I'll refer to my diplomatic answer. Thank you, Senator, on particular hospitals.
And this is Dave on the telehealth policies that we've implemented under the pandemic. Yes, they're paying at parity now. We move those there. We obviously are evaluating those as we go forward, but we think that clearly telehealth is one of the most important things that we will continue once the pandemic's over.
And I think this is just a more general question. Do we, from Representative Lambeth, do we plan to talk about other access opportunities, access to capital, telehealth, doctors, nurses, et cetera? Yes, when we get to after the Ohio presentation, I wanted to make sure the group can talk about what we should talk about in our next meeting. And we certainly want to open the door to talking about other ideas on how to improve access to care in North Carolina. So can definitely take on those topics at future meetings. So thank you for mentioning that. Okay, great. Anyone else have a burning question? It looks like some others in the chat are just comments. Anyone else has a question, please speak up.
Representative Cunningham, I had a question, and I'm not sure if Dave should answer it or not, but one hospital recently stopped doing mental health psych services here recently. And from what I understand is that it's not a financial, income for revenue within those facilities, and that's why a lot of them stopped doing it. But without them being able to provide those services, there's a lack. So can we elaborate on the cost of providing those services without Medicaid expansion and break it down so that we can see why the hospitals are starting to stop doing psych services like in their facilities in cases you have to be inpatient to provide those services other than the telehealth aspect?
Dave, you're on mute.
I unmuted and muted myself all in one swipe. I would be happy to pull together some presentation for that for maybe the next meeting, so we can put that as part of that process. How's that?
Great. Okay. With that, I think we'll go to our next speaker. I wanted to introduce Greg Moody. Greg is an executive in residence at the John Glenn College of Public Affairs at The Ohio State University, and he served as the director of the Ohio Governor's Office of Health Transformation. And he wanted to just talk briefly about their experiences in Ohio. And again, I was going to remind everyone, Medicaid expansion is just one of the things we're going to talk about in the course of these meetings, but today this is what we plan to talk about. So he's going to talk specifically about his experience in Ohio, and please ask any questions in the chat as you've been doing. Turn it over to Greg.
Great. Hello, everyone. Very glad to join you. I really appreciate the invitation. As Hammy mentioned, I'm currently at the Glenn College, but prior to that, I was the director of Ohio Governor John Kasich's Office of Health Transformation. And we operated a strike team tasked with aligning health policy reforms across all of Ohio's health and human service agencies. Some of what I'm going to say is just a variation on a theme from what you've heard already from Hammy and Dave and Mark. But I wanted to share some of the themes that really resonated in Ohio and had the effect of accomplishing expansion. And also that these are actual data points. This is our history in Ohio. So it's not the projections of what might possibly happen, but some of our actual experience. First slide. So the starting point is we really did not set out to expand Medicaid. When our team took office in 2011, Ohio Medicaid was growing more than 10% annually, and the state had an $8 billion budget deficit. There was a general lack of belief in government, and under those conditions, the governor made it clear that he was not going to expand Medicaid. Our goal was to improve overall health system performance, better health outcomes, and better stewardship of taxpayer resources. We launched an aggressive set of reforms that you see in the list there. Your work in North Carolina actually parallels our path in Ohio. Rebid managed care to be more efficient, increase access to primary care, and engage partners to pay for value. These reforms worked for us. They worked really well. And if you advance the slide again, within 2 years, Ohio Medicaid was growing less than 3% annually. And largely from Medicaid savings, we eliminated the state budget deficit and set aside $2 billion in our rainy day fund. Under those circumstances, we were able to consider expansion. Next slide. In addition to holding down spending, we achieved steady improvement in overall health system performance. This ranking is from the Commonwealth Fund state scorecard, but there are others and results are similar. Our reforms jumped Ohio 6 spots on this relative ranking, up from about where North Carolina is today. Looking back, it's clear to me that we would not have achieved this gain in overall health system performance without Medicaid expansion. In fact, and if you advance the slide, Ohio pulled away from other states that have so far chosen not to expand. The non-expansion states all perform at or below the national average in terms of overall health system performance. There are strong parallels between Ohio and North Carolina. Similar size, similar politics. We both have some of the best health care providers in the world. and we also have some of the worst healthcare outcomes in the country. There is a disconnect between our capacity to provide high quality care and making sure our citizens, all of our citizens, have access to the care we're providing. For Ohio, that's where the Medicaid expansion came into play. Prior to the expansion, Ohio Medicaid covered children up to 200% of poverty, parents to 90%, persons with disabilities at about 100. This is very similar to where North Carolina is today. This is what Dave covered in his presentation. The Affordable Care Act filled this in above 100% of poverty, and after the Supreme Court decision gave states the option to fill the remaining gaps by expanding Medicaid to 138% of poverty. Governor Kasich's translation of this chart is that expansion is a matter of justice. He would not have chosen to have designed health reform this way, but as governor, it was the hand he was dealt. And the result is that some Ohioans at higher incomes are granted a benefit that is denied to others who are more vulnerable. And that's an injustice that in his view, he could remedy through expansion. Much of the opposition we faced to Medicaid expansion arose from misconceptions about who falls into that coverage gap. And this has been covered very well already, but it was true in Ohio. More than half work. Many have a serious health condition that prevents work. There's a large group age 55 and older, a large group caring for children, a large group of uninsured veterans. In Ohio, we also enacted a work requirement, and after exempting groups that our conservative legislature had waived, the groups I just mentioned, only about 5% of the individuals in the coverage gap were identified to be able but not working. There was also an undercurrent of the urban-rural divide. Many in the legislature, on the next slide, viewed the expansion as an urban-only issue. And it's true that most expansion-eligible residents are concentrated in Ohio's urban counties. However, if you advance the slide, the highest percentage of expansion-eligible residents live in rural counties. In several of these counties, nearly 15% of the population qualifies for the Medicaid expansion. In other words, without expansion, 15% of these legislators' constituents are left without coverage. By the way, this is the dynamic too that was at the root of our rural provider crisis. And fortunately, we have so far been available to avoid any of our rural hospitals going out of business. Uncompensated care was putting them at risk, but the Medicaid expansion was a lifeline at the right time that kept providers operating in rural areas. Often that healthcare provider is the primary employer, as folks have discussed already. Much of the support for Ohio's Medicaid expansion came from hospital systems and health plans, and that was critical. But you'd expect that because those organizations gain financially. The more compelling support for us came from the rural hospitals that otherwise were going to close, chambers of commerce, tired of businesses subsidizing a cost shift in those hospitals, Right to Life because Medicaid restricts access to abortion, veterans organizations. Our strongest and most unexpected support came from sheriffs who were fed up with untreated addiction in jails. They were the most outspoken advocates for expansion as a strategy to divert individuals struggling with addiction into appropriate settings of care rather than letting them default to jails. In fact, we were able to do this. Over 5 years, the Medicaid expansion allowed us to increase Ohio's behavioral health system capacity 60%. That's more than $1 billion annually now flowing into our communities to shore up mental health and addiction services. It's allowed us to connect prisoners to care before release and reduce recidivism. And it provided resources we needed to combat the opioid crisis or any crisis like COVID. This is currently a real disparity. States like Ohio combating the opioid crisis and COVID with federal expansion funds, while states like North Carolina have to rely more on state-only funds. We saw other benefits as well. Before expansion, there were concerns that expansion would create waiting lines for primary care, particularly in rural areas. The reverse was true. The expansion significantly increased our capacity in primary care infrastructure and stabilized practices in rural areas. Before expansion, there were concerns that a woodwork effect would overwhelm the Medicaid program and reveal hidden costs in the next slide. I never really understood the woodwork argument, because if a person is eligible but not enrolled, that's the woodwork. We want them connected to care. But in fact, Medicaid enrollment was in line with what we predicted and remained stable throughout the expansion. It did not displace employer or non-group coverage. It simply converted the uninsured into covered lives, compensated care. Before expansion, there were concerns that expansion spending would get out of control and ruin the state budget. Of course, spending did increase because we increased enrollment to cover previously uninsured Ohioans. But on a per person basis, we were able to keep Medicaid spending growth flat for 5 years during the expansion. And I credit our Medicaid managed care reforms as being largely responsible for this result. Before expansion, there were concerns that expansion costs would overwhelm the state budget or federal funds would be taken away. 7 years later, the federal funds are still there, and the most recent challenge to the ACA seems unlikely to change that. Also, it may be instructive to see the actual impact of the expansion on Ohio's budget. This year, in fiscal year 2021, the expansion costs $5.3 billion, and the state share is $534 million. However, the expansion results in additional drug rebates, prison costs the state used to pay that are now covered by Medicaid, and the additional volume of expansion services is taxed through our managed care program. These activities offset state costs. The actual state share is $161 million. Or about 3% of the total cost of the expansion. Ohio spends 3 cents for every dollar of economic benefit coming into Ohio through the expansion. One of the real benefits, I think, for where you are in your decision-making is other states have generated data for you to review. I won't go into this in a lot of detail. It reflects some of the data Hammy was sharing, but I just wanted to reinforce that for Ohio, the benefits were very clear. Better access to care, emergency department use decreased, many people detected previously undiagnosed chronic conditions, health status generally improved. The assessment specifically focused on the impact on work. A higher percentage of expansion enrollees are now employed and have access to primary care providers. And as I mentioned, emergency department use is down. Before expansion, there were concerns that the new enrollees would stay on the rolls and drive up Medicaid spending. In fact, for many enrollees, the Medicaid expansion is a stepping stone to greater economic self-sufficiency. Only about 1/3 of the individuals who ever enrolled under Ohio's expansion maintain continuous expansion coverage. Most who leave expansion coverage say it's because they got a job or other coverage. For those who return to expansion coverage, more than half say it's because they lost their job. The expansion supports work and the gaps between work. It's a powerful workforce support in addition to generating significant economic activity in our communities and a lifeline for otherwise uninsured Ohioans. One last thought, and as a longtime policy person, this really surprised me. Throughout the expansion, we had to deal with false statements and misinformation about the program. You are, I think, in a better position because these claims have been proven false over time, but I still sometimes see them quoted or repeated in stories. The most surprising was a US Senate report that claimed Ohio's expansion enrollment was over projections and costs were surging, none of which was true. For our team, it took discipline to stay focused on the work and not get too distracted by false claims that in the end evaporated without impact. So again, I appreciate the invitation to join you. I commend everyone on this call for taking the time to understand the details of an issue that really does have the potential to reshape health system performance in North Carolina. Of course, wish you all the best in what you're doing next. And at this point, I'd be very happy to respond to any questions.
Wonderful. Thank you, Greg. Senator Kroc did have one question. If one has a serious health issue, shouldn't they already qualify for a disability benefit? How did that play out in Ohio?
Yeah, and of course, there are two ways to enter the program. The simplest is just an income test, where in Ohio now, if your income is below 138% of poverty, you come into the program. And then if you have a disability, that's an additional qualification based on additional services you might need access to. Previously in Ohio, if an individual had a disability, they did qualify for the Medicaid program. So the expansion did not necessarily pick up individuals with disabilities who weren't on Medicaid. However, for example, childless adults were not covered, and if they had a mental health or an addiction issue, they were not covered.
Great, thank you. Other folks that have questions, please chime in. I think Greg presented a lot of really interesting data about how things played out in Ohio. So please ask your questions. Questions? Comments? Okay. All right. Well, thank you, Greg, for that fantastic presentation. And as I mentioned, I will go ahead and we are going to go ahead and make sure we post all of these presentations to the website, as well as sending it out to you all individually. So you will get the copies of these after we conclude this meeting. Oh, here's a question. Cassandra Brooks, can you go into more detail regarding how you were able to get the pro-life groups to help push for this change, referring to the Hyde Amendment?
Yeah, one of the, I think, most effective things we did was a process actually very similar to what you're doing now, where we really had a come one, come all approach to the Coalition for Expansion. And even in how we communicated, we set up essentially an email group that anybody who wanted to be a part of could be on. So we were always communicating information about the expansion in the same way to everyone. I think prior to that, there was a suspicion that we were trying to cut special deals with certain providers, or we were politically looking out for one group over another. So what we did was just share any decision we made along the way at the same time with everyone. Out of that process, a few groups emerged that actually we did not recruit, but they approached us. And Right to Life, that was the case, where they both supported access to healthcare, particularly for potential young mothers who were not yet connected to care, who, if they became pregnant, they'd be connected via Medicaid, but the idea of getting them access to health services earlier to have healthy pregnancies. That was a focus for that organization in Ohio. And by the way, they supported the Hyde Amendment. So the combination of those policy considerations, they stepped up really early in the process to support the expansion. I mentioned the sheriffs. I got to say, I think our expansion with the legislature was largely achieved by county sheriffs themselves going to our state house and strongly advocating for this, because they, on the ground, in the field, were seeing folks that really they should not be dealing with, who they were paying for in their facilities to provide healthcare, simply because that individual was not connected to a regular source of care. And it's something to see a group of 20 sheriffs walking into the State House together to advocate for Medicaid reform. So some of that, I wish I could say it had been our idea to put the coalition together that way, but honestly, a lot of it just occurred organically, particularly from folks actually living these experiences in communities where the consequences of having a lack of access to coverage are felt the strongest.
Great. We do have one question from Representative Cunningham. Asking about gender breakdown for expansion coverage, interested because of opioid SUD.
I'm sorry, say it again.
Gender breakdown expansion coverage, interested because of opioid SUD. And Representative Cunningham, if you want to come off mute and expand on that, please feel free to do that.
Hey, this is Representative Cunningham. What I'm looking at is that there was a significant opioid use out in Ohio, and the numbers decreased significantly, but the group that mostly was doing the opioid or substance use were males. So when we start looking at gender, I'm interested in the gender because it did drive your numbers down, but still that group were males. So some states did include males in their expansion. So I didn't know what Ohio had done.
Yeah. And this is a heartbreaking issue for me because, Ohio was one of the states that was disproportionately impacted by the opioid crisis early on. And we really rallied resources in response. And I've got to say, I don't know what we would have done without having had the Medicaid expansion resources available to us in that effort. And that full court press let us in a single year decrease opioid related deaths 20%. We thought we were headed in the right direction. And then COVID hit, and many of those statistics have reversed themselves again. I would say the same thing about COVID. I can't imagine the state right now having to take that on with state-only resources or relying on only CARE Act resources without having kind of the underpinning through the provider payments we're able to do through the expansion. Within our expansion group, for us, it's simple. Below 138, you're covered by the expansion. So that's men and women, and you are correct that our biggest reductions in opioid deaths we're seeing in men, but that issue, of course, is hitting everyone.
Great. Representative Adcock had a question. Were there things Ohio included in his plan that were unable to be achieved for lack of support or in a proposed plan?
Yeah, this was really interesting because we wanted to do something unique. And at the time we were partnered with Arkansas. And I think not a lot of folks maybe remember that Ohio and Arkansas were working together on a special version of expansion. What happened was the administrative complexity of that was so extreme. And as we started working with our legislators, and here I'm not talking about North Carolina, I'm just talking about Ohio. As we were working with the legislators, particularly in the House, the more complicated the solution was, the more nervous they were that there was something that we might get wrong. And at the end of the day, keeping it simple mattered. And the idea that we have a simple income test and below 138% of poverty, you're eligible, that is what carried the day. Subsequent to that, there was a concern that some in that group maybe were able and not working and should be subject to a work requirement. So the legislature, a year after we expanded, enacted a work requirement, which then, as I described, once we really got into it, the effect of that was minimized because they then wanted to waive groups they didn't want to be subject to the work requirement. So over 55, a health condition that prevents work, staying at home caring for a child, engaged in education, actively pursuing education. So once we waived those series of issues, we were down to about 5% of the expansion group that we actually would apply the work requirement to. So that, I would say, was a political consideration where folks wanted to do something specific in that space. And the executive worked with them to accomplish that. Although I've got to say, we warned folks all along that the administrative complexity of that might not be worth a work requirement that you apply on only 5% of the population. But that is currently the law in Ohio.
Fantastic. And I think that might have responded to Senator Representative Adcock's follow-up. Okay. Any other questions that folks have? Before we talk about next steps?
Actually, that didn't, my second.
Oh, it didn't. Okay.
Totally different question. If you don't,
okay, please
I'll just say it out loud. And that is,
yeah.
what other legislation was needed? Like what kind of regulatory reform? What kind of financial package? What other kind of legislation that was part of the package, not specific to Medicaid expansion, but improve the environment for its success? Did Ohio either pass and or consider?
Well, and on this, we could have a whole separate conversation on some of the nuances in Ohio, which might not be that helpful to you. The actual amount of legislation required this was minimal. We wrote the state plan amendment and got it approved by the federal government. That created the authority to expand. Technically, all we needed to accomplish the expansion was a state appropriation to receive the federal dollars. Normally, you would do that outright through your budget. In Ohio, we have something called a controlling board, which is a subcommittee of the legislature that has the authority to address federal appropriations. That subcommittee made the adjustment to receive the federal funds. And simply with the SPA and that action by that committee, we were able to expand coverage. Otherwise, there wasn't significant change, for example, in insurance law. In Ohio, our Medicaid director has a lot of discretion to instruct our managed care plans how to operate. So everything we needed to do with our managed care plans to ensure network adequacy with the expansion, we were able to do that directly between the program and the providers without additional legislation. And again, at the end of the day, simple ended up being something that everyone was interested in. But that was Ohio.
Thank you.
Okay. Any other questions? I don't see any in the chat, but please feel free to just go ahead and ask while we have Greg.
And follow up. I'm happy later to respond to any questions. And as we wrap up this part, I've got to say this was a pleasure for me. I really do wish you all well.
Hey, Greg, this is Tunde. Just have a quick question. So state plan amendment, that simple. I know it's never that simple. No 1115, 1915, no waiver submissions required to CMS.
We did it through the standard expansion where we checked the boxes and submitted the waiver.
Wow. Okay. Thank you.
And again, and
could I? Sorry.
Well, I was just going to say it's one of the political considerations, depending on what your dynamic is. Everything that deviates that, where you want to create authority to do something different, you have to get votes to do that thing that's different. And we found on this subject, the fewer votes you had to cast related to expansion was easier than trying to do something that was original, but that required changes in the underlying authority. And again, we tried doing something original, and we spent actually quite a few months working directly with our legislature to do that. And in the end, it was really their request to not put them on the hook to cast a series of votes. And they preferred that the executive take the responsibility to go ahead and make as much progress as we could without requiring those votes.
I think Senator Woodard wanted to chime in. Go ahead, Senator.
Yeah, thanks. Greg, correct me if I'm wrong, but I think Ohio does have certificate of need laws. Following up on Gail Adcock's question, did CON enter the discussion at all? And did you all make any changes to your CON as part of your expansion?
Yep, we did not, and Ohio is unique in this regard. We might be the only state that doesn't technically regulate hospitals. We do have a very aggressive CON on nursing facilities. So normally when Ohio is in a CON conversation, it's on that side of the equation, which wasn't in play here. So and regulating hospitals is another issue that I'll not get into with you here. But so no, we did not have to make any changes in underlying CON requirements.
Great. And I think Dr. Newton raised a hand. Yeah, there it is.
Yes. Wanted to ask Greg, I may have missed that in your presentation. Was broadband access, particularly in rural areas, an issue in Ohio? Because I see that a lot in my own practice. The increasing telehealth that we've used during COVID is good, but it's limited a lot, at least in my area, and I think it is across the state, by access to broadband.
Yeah, and it's so hard now that we're so many months into this to kind of find the constructive elements of this. But in Ohio, COVID for us really was the turning point in opening the door to more access to telehealth. So after expansion through our managed care plans, we had turned on service payments for certain types of telehealth, but it was still really limited. And even though we were paying for it, it was significantly limited in certain communities because of the broadband access. Now we're going through another reprocurement of our managed care plans, where broadband access is actually envisioned as an expectation through that procurement. So leveraging the role of the plans in communities to ensure access to broadband for telehealth. And it is one of those areas where I think we're learning some things that are a better way of doing business, that on the other side of COVID, I hope we're able to see that through.
Thank you. Okay, well, just wanted to say thank you so much to Greg Moody for the great presentation. I know we only have 15 minutes left, and I do want to pivot quickly just to talk about next steps and really have a little bit more of a discussion amongst all of you. So first of all, really appreciate again your attention and your participation in what I think is an incredibly diverse and thoughtful group here. We wanted to talk a little bit about expansion today because it is such a big lever in thinking about improving access to coverage. But the purpose of these meetings is to talk about a lot of other topics as well. And so the next meeting we have scheduled, which you will get information about, will be December 18th. And there will be a follow-up meeting on January 8th. And for the December 18th meeting, I wanted to really engage all of you to ask about other topics that you may want to address. We can certainly talk about some of the things we raised today, you all raised today with respect to financing, et cetera, but also would like to hear about what else is on your mind. Telehealth came up in one of the discussions, behavioral health, where we could talk as a group and make sure we have some content to present and discuss next meeting. So I don't know if anyone wants to start in terms of what would be of most importance for our next meeting.
Hemi, this is Senator Kravic.
Yes.
I just want to add a lot of information today. We've really hard to take it all in, so I'm glad you're making it available online. To be honest, I was a little disappointed when I saw we were starting with Medicaid expansion. So because it has been such a controversial topic. So I'm glad that we're moving on to other things. But we also know that in order to improve access, we need to find ways to reduce costs. So I was glad to hear some of those issues addressed. One of the, Senator Woodard brought up the certificate of need that we've worked on last session. I think that's really important that we look at that. So I hope that we'll consider, talking more in depth about that at some point. The other thing, we had a bill last time that we passed for association health plans. It came up in the discussion that so many businesses do not provide coverage for their employees, but the association health plan opened that up. We estimated it was going to cover about another 150,000 people in North Carolina by enabling those businesses to be able to purchase reduced insurance as a pool to go gather together, just like the big insurance companies do. Business community was overwhelmingly behind it. It's a great idea to improve coverage to a lot of those folks, particularly in some of those low wage industries. So I'm looking forward to it. That was held up because there is a court case in another state.
Yeah.
I personally think we need to move forward with it anyway. We have no idea when that decision is going to be made. It's just prohibiting a lot of people from getting the coverage that they could get. I was glad to see us talk about telehealth and how we can improve that. We've seen how beneficial it's been during COVID. So I'm hoping that we'll hear a little more about that and find some ways that we can do that. Also hope we'll talk about recognizing out-of-state licenses for providers, so it makes it easier for them to come here and practice, to not have to go through. Many states have done this, and I think we can do it safely, and we can do it right. So I think that would help as far as increasing providers. I also want to see us look into state reinsurance plans. I don't know how many of you are familiar with that, but other states are doing it. It does take a waiver to enable that, but I think it's worth pursuing. So just some of my ideas. I also want to say I was also a little bit disappointed that we didn't include one of our most well-known health policy think tanks in North Carolina, the Locke Foundation. And maybe that was just an oversight, but they're constantly coming up with ideas for health policy. So just wanted to throw that out, but thank you all so much. That was a lot of information. So I'm looking forward to hearing more.
Okay.
Thank
you so much.
This is Representative Lambeth. Could I build on the comments made by my Senate friend?
Yes, go ahead.
I think this is a very broad topic, quite frankly, and I am a little disappointed we spent so much time just on expansion. But telemedicine is an integral part of meeting access needs, particularly in rural North Carolina. I hear a lot about the difficulty that rural access issues because they can't recruit physicians, they can't recruit nurses, they can't recruit nurse practitioners, and whether there ought to be programs such as loan forgiveness, incentives to get caregivers to go into some of these difficult to serve areas. And I could go on with topics that I think are very important for access and to improve access. And I think many of those that Senator Crowley mentioned are important that we look at as well. So I think there's a lot we can talk about and can in fact improve on it. Expansion of broadband to enable telehealth. So actually, I think this is a good topic for us to kick around a little bit to see if there's something that good can come out of it. And I just want to add those few things that Senator Crowley added.
Yes,
This is Representative White, and I'd like to add one more.
And then I have to go to Representative Cunningham, who raised their hand. But yes, go ahead.
I just wanted to add that we really need to address the issue of scope of practice. Each discipline should be able to, each health practitioner should be able to function at their current state scope of practice without so much regulation that has nothing to do with their abilities and their scope of practice. So I think that is one of the issues that we really need to put at the top of the list to discuss, because that would certainly increase access to a lot of the rural communities. Thank you.
Thank you. Representative Cunningham, you've been waiting patiently. Go ahead.
Thank you so much. I would like to also say behind Representative White, that is one of the things that I also, and I'm sure Gail Adcock would say it too, is looking at that advanced practice for our physician assistants, nurse anesthetists, and our nurse practitioners. When the ACA was created for it to be done, it included that those individuals that have advanced practice would be able to fulfill the gap where primary care physicians weren't available because of the short turnaround for them to become active in our communities. But I don't want to get stuck on that, and CON is another issue. But also is, as we're going forward, to look at the needs of the people of North Carolina. Where are we going to be once COVID settles down? The expectation of the increase in mental health needs, the expectation of long haulers surviving, and more people becoming disabled and unable to work that will fall into the Medicaid or fall to Medicaid and Medicare. The trajectory, we still don't know. So I think the data is being collected. We don't know yet the suicide rate increase uptick possibly because the data is just not available. But we do know that domestic violence increase. We do know that child abuse increase. Those all have impacts on the healthcare. I say if you can't breathe, you can't read. And I think that is the aspect that I'm in as far as providing that healthcare for the people of the state. They are struggling now, but they will be struggling more as the coming months and the data is revealed. And so I would like to see us try to bring everything to the table that could support us moving forward in how we assist the citizens of North Carolina and the entire state becoming a more healthy state. Thank you.
Thank you, Representative Cunningham. Other suggestions for our next meeting? There's a lot of good topics here already.
Hi, this is Kenya McNeil-Trice. Thank you so much again for allowing me to participate. I would also like to bring more emphasis on childcare as a, not only as a representative for our Pediatric Society, but as a practicing physician and hospitalist. This Medicaid expansion and coverage disparately impacts children in this state. If you are a parent whose child is not healthy, you cannot work. Children cannot access school and other resources if they're not healthy and don't have access. They are not able to have voices and seats at the table. And so children disparately represent the number of patients who are on Medicaid. And you cannot have a practice who takes care of children unless you accept Medicaid. That should just let you know the number of citizens in this state that this impacts. And I see it daily, regardless of how they identify culturally, ethnically, racially, religiously, regardless of how their families identify politically. It has no barriers. And so I would love to have a discussion that focuses on how we're going to advocate for improvement of care for children so that they have an equitable access, because they are disproportionately represented in our Medicaid patients, but also maternal child health. If we don't have healthy mothers, the chances of them having healthy pregnancies is minimal. And losing Medicaid coverage 6 months after you deliver is just not okay, regardless of your age or pre-existing healthcare status. So I would love to see some more documentation and data, because it definitely impacts children in rural communities, but it really impacts children in urban communities. There are no barriers to how this is impacting children in North Carolina.
Thank you for that. And I think Representative Adcock, go ahead, you were next.
Yes, oh gosh, we could meet for 6 months. This is fantastic. So I just want to go back to what Senator Kravick said about looking at what our employers need. I really think we need to look at what other tools business needs to ensure their employees. I was taken by what Greg Moody said about how increasing access to health insurance is a workforce support. So I think that is something that we could really hear about from those businesses themselves, what they feel would be most helpful to them. And then I do want to add that I do believe our state has an opportunity to look at other changes, other kinds of reforms that will support whatever plan or plans we come up with to increase access to health insurance. And one of those is to allow the entire healthcare workforce to work within their full licensure so that we can really take advantage of deploying our entire workforce. And that is because our physician colleagues are doing valiant work and just cannot do it all themselves. There's just from Murphy to Manio, we have all these great needs. And I believe there will be some other great pieces of reform that we can take up that will support this big effort that we have. Thank you.
Oh, thank you so much. Jean, go ahead. Yes.
I think there's been a lot of conversation about just behavioral health. This is a pretty big agenda. We've added a lot of things to the list. I just want to make sure that we come back to that. I have 180 people in my emergency rooms right now as we speak looking for placement. A lot of those are kids too. We have kids that are sitting in emergency rooms for weeks on end for lack of a place to place them. None of us could want our children in that scenarios, but we literally, nobody can take them. And so as we look to this long agenda, I do think that we can't do Medicaid expansion, we can't do population health, we can't really take care of our communities without putting that front and center. And it hits every single aspect of the healthcare system, inpatient, outpatient, what the networks are surrounding that, telehealth. So I really hope that as we look at this long agenda, that gets put at the top of the list. And we have an urgent issue right now as we speak, trying to figure out where are we going to put these patients that have needs today.
Yeah, no, thank you. And I know we're at time, and this has really been a fantastic discussion. We have a lot of things on the list, and I appreciate sort of the interest in hearing directly from what's happening on the front lines and what's going to be helpful to really improve care in North Carolina. So I will close this out. Feel free to send us any additional thoughts by email. Elaine sent out all the information from the appointment, so you can respond to that and give us any other ideas that you may have for the next meeting, and we will incorporate those to the best of our abilities. And we will go ahead and propose an agenda, because the next meeting is December 18th, fairly quickly, and get that out to you so you can see the topics we're going to cover. And there's certainly a lot here that we can cover. We may not be able to do them all in the next meeting, but we certainly will do some of them because these are all very important issues. I have to say thank you again for your time here. And I don't know, Secretary Cohen or Dave, if you want to say anything else in closing. I don't think we still have the governor, but.
I don't think we still have the governor, but
yeah.
Thanks everyone for a good morning of discussion. And I want to thank Senator Krovic in particular for outlining a number of issues that I would like to bring into the discussion here, as well as making sure that, actually inviting someone from John Locke to potentially present at the next meeting. I know they have a number of ideas, and then because we really need that marketplace of ideas on coverage. I do want to make sure that we it's a coverage council. Yes, it sits in the coverage is a piece of access, which sits in the larger cost and healthcare system. And I know all the big hearts on this call want to solve all the problems. I'll try to keep, encourage us to stay focused, but I think there are a lot of important ideas that we need to surface in. Again, it's good to get into these policy weeds, but ultimately I hope we can lift back up as a group to those priorities that I hear a lot of shared alignment on. I keep hearing repetitive themes, particularly on those priorities and those principles. And then I think there are different tactical policy ways that we could go about it. So, Hammy, I'm going to look to you and your team to help us sort of structure that next conversation, so we can think both at the high level of principles, but also some of these different tactical ideas, and make sure that we are inviting others. So expect follow-up between meetings, and I'll probably follow up individually with a number of you who have already reached out with some good ideas. So just thank you. I think really good start, but expect a lot more to come. So thank you.
Yeah. All right. I hope you all have the rest of your Friday to yourselves, or for something else that's interesting. And really thank you for your time, and we will be in touch. And as Mandy said, please reach out, and we will reach out to you as well. So we'll see you in 2 weeks.